Hello and welcome friends. Today is the third talk of the resident series of the ACNS webinars. And for today's session, we are fortunate to have with us Professor Prof Mori, who is the Chief of the Cerebral Stroke Center, Department of Neurosurgery, Tokyo General Hospital, Japan. Professor Mori is also the visiting professor at the Department of Neurosurgery at the Juntendo University, Tokyo, Japan. Professor Mori is very supportive for the educational initiatives of the ACNS, and he travels with us around Asia, teaching the young neurosurgeons and the residents. He has published several articles and is a pioneer for the minimal invasive aneurysm surgery. Today, Professor Mori is going to talk about cerebral vasospasm and its treatment following subarachnoid hemorrhage. To chair this session of Professor Mori, we have with us a very special guest who accepted our invitation to chair this session despite this being a very odd time for him at his place. Ladies and gentlemen, please welcome Professor David Hassan, who is the chair of Department of Neurosurgery, University of Iowa Hospitals and Clinics, Iowa, United States of America. On behalf of the Education Committee and the President, Professor Yoko Kato, I welcome both the speaker, Professor Mori, and the chair, Professor David Hassan, to this online platform of the ACNS webinar. Now, may I please request Professor Mori to start his talk.
Is caused by ruptured intracerebral aneurysms. And the rupture of the cerebral aneurysm causes a devastating effect on the brain. And roughly speaking, about 12% of the patient died before they came to the hospital. And 40% of hospitalized patients die within 1 month. And 1/3 of the survivors has a major neurological deficit, mainly due to vasospasm. And only approximately 1/3 of SAH patients return to their normal life. And this is histological picture of the cerebral arteries in the subarachnoid space. And the left one is normal cerebral artery, but after the subarachnoid hemorrhage, vasoconstriction occurs in the arteries. And this is a typical histological picture of cerebral vasospasm. And this is angiography taken after 7 days or 10 days after the ictus of subarachnoid hemorrhage. And bilateral MCA, especially M1, and the right side, especially right side, M1 suffered from vasospasm. And as a result, right MCA area showed the severe infarction. So this patient, I suppose, has a severe neurological deficit. And vasospasm, there are two kinds of vasospasms. One is angiographic vasospasm, the other is symptomatic vasospasm. And angiographic vasospasm occurs about 70% of the SAH patient, and 20 to 30% of the patient shows a so-called symptomatic vasospasm. The definition of symptomatic vasospasm is that patient shows a decreased consciousness level or focal neurological deficit without hydrocephalus and without electrolyte disturbances. And nowadays, many neurosurgeons use the words delayed ischemic neurological deficit or delayed cerebral ischemia instead of symptomatic vasospasm. And delayed cerebral ischemia causes cerebral infarct during the day 4 to day 14 after subarachnoid hemorrhage. So even if a neurosurgeon successfully treats the ruptured aneurysm, 1 week after, patient may have severe neurological deficit due to vasospasm. So still it's a very important matter for the patient and the neurosurgeon. And 10 years ago, vasospasm almost equal to delayed cerebral ischemia. However, nowadays, vasospasm is not sole cause of delayed cerebral ischemia. So I will tell you about this new issue. And in 1970s, 20 to 30% of the patient shows the mortality and morbidity after the subarachnoid hemorrhage in Japan. And in 1980s, 15 to 20% of the Japanese patients shows mortality and morbidity. And currently, 5 to 10%. So the incidence of the delayed cerebral ischemia in Japan has been decreasing. I think this is due to the improved post-operative management and several anti-vasospastic agents. And I wanted to speak about the mechanisms of vasospasm and delayed cerebral ischemia, because vasospasm can be induced by several different mechanisms. So as you know, after the subarachnoid hemorrhage, blood clot deposit in subarachnoid space. And this blood clot produces the oxyhemoglobin. And oxyhemoglobin causes peripheral vascular nerve damage. And also oxyhemoglobin disturbs the nitric oxide metabolism. And also oxyhemoglobin produce the arachidonic acid metabolism, increase the arachidonic acid metabolism, and release the endothelin from the arterial wall. Also, oxyhemoglobin triggers free radical reactions. So these many factors cause the vas constriction in the arterial wall. So as you know, in the smooth muscle cell has several calcium channels, such as voltage-dependent calcium channel and receptor-operated calcium channel. And also there is a G protein coupled receptor. And using those calcium channels, extracellular calcium influx into the intracellular space. Also, inositol triphosphate receptor, if stimulated, intracellular calcium released into the increase the intracellular calcium concentration. These increased intracellular calcium stimulate myosin light channel kinase, and myosin light channel kinase change the myosin light channel into the myosin light channel phosphate, and myosin light channel phosphate cause muscle construction, smooth muscle construction. And also diacylglycerol stimulates the phosphokinase C, and phosphokinase C inhibits myosin light channel phosphatase. So myosin light channel phosphate cannot return to the myosin light channel channel. So increased myosin light channel phosphate cause muscle construction. So vasospasm happens. And as you know, there are several calcium channel blockers, such as nimodipine, nicardipine, and magnesium. They can block the calcium channels. And also low kinase A released by a small G protein on the smooth muscle membrane, and low kinase also inhibits the myosin light channel phosphate and then cause a muscle contraction. And Fascigel was made by Japanese pharmaceutical company and prohibits the low kinase, and this inhibits the muscle construction. I think Fascigel is very feasible drug. I don't know Indian neurosurgeon can use this drug in India. And also oxyhemoglobin induce free radicals such as superoxide and hydroxyl. These free radicals, such as superoxide, cause nitric oxide inactivation, and also hydroxyl free radical stimulates the phosphokinase T pathways. So therefore, free radicals cause a vasoconstriction. And also, as you know, after the subarachnoid hemorrhage, arachidonic acid cascade increase. And phospholipase A stimulates the production of arachidonic acid, and arachidonic acid change to the prostaglandin G2 by cyclooxygenase. And prostaglandin G2 change to prostaglandin AH2. And prostaglandin H2 change into two kinds of mediators. One is thromboxane A2. This is potent vasoconstrictor. And thromboxane A2 also causes platelet aggregation. But prostaglandin I2 causes vasodilatation. And as you know, phospholipase A2 can be prohibited by steroid, and cyclooxygenase activity inhibited by aspirin, and ozagrel blocks the thromboxane A2 synthetase. Therefore, steroid and aspirin, ozagrel, they are also candidates to suppress the vasospasm. And the nitrous oxide, it's a kind of transmitter in the brain, but nitrous oxide is very complex. I'm not a specialist of NO, so I don't want to say too much. But after the subarachnoid hemorrhage, NO activity decrease in the brain, and it causes vasospasm. And also, after the subarachnoid hemorrhage, the endothelial cells produce the endothelin 1, and endothelin 1 stimulates the endothelin A receptor, and it causes strong vasoconstriction, long-term vasoconstriction. So many neurosurgeons expected endothelin 1 and endothelin A receptor is very important mechanism to cause a prolonged vasospasm after subarachnoid hemorrhage. And clazosentan is a famous ETA receptor antagonist. So we expected clazosentan would solve the problem of vasospasm, but it was not. I will tell you about that story later. And this is a histological picture of the basal artery after the experimental SAH dog experiment. And this is a spastic basal artery in dog. And you can see the edematous change with inflammatory cell infiltration in the adventitia of the arterial wall. So still inflammation and denervation may be one of factors to cause the vasospasm. So vasospasm can be caused by calcium-dependent vasoconstriction and calcium-independent vasospasm and free radicals and swelling, inflammation, decreased NO, and neurogenic factors, and apoptosis, and arachidonic acid metabolite. So very multifocal situation, I think. And so this is a summary slide of the therapeutic agent for vasospasm. One is clazosentan, ETA receptor antagonist, and ozagrel. Ozagrel suppress the thromboxane A2 synthetases, and fasizil is a strong low kinase inhibitor, and statin suppress the inflammation and NO. So there are many drugs to treat the vasospasm, but none of them are complete, I think. And recently, several neurosurgeons, especially German group, think cortical spreading depolarization is very important to cause the delayed cerebral neurological deficit. They found that in the patient with cluster of recurrent cortical spreading depolarizations were measured that were consistently associated with cerebral hypoperfusion. And cortical spreading depolarization in the normal brain caused by noxious stimuli of the brain, such as the stitch stimulation or potassium stimulation. In the normal brain, cortical spreading depolarization increase CBF and oxygen delivery. However, in the pathological brain, especially if the microcirculation system is disturbed, cortical spreading depolarization cause decrease spreading cortical CSD decreases CBF in the pathological brain. So we call this phenomenon as spreading cortical ischemia. So German group, cortical spreading depolarization is a key factor to cause delayed cerebral ischemia. And another group in the United States introduced a concept of early brain injury. And early brain injury is that after the subarachnoid hemorrhage, intracranial pressure increased rapidly, and increased intra-ICP caused a global cerebral ischemia. And this global ischemia, even if it is a transient, it causes a blood-brain barrier disruption and inflammation and oxidative stress and apoptosis, etc. And these phenomena, still there is not a clear cascade. We have not found cascade, but these factors may cause the delayed cerebral ischemia. So early brain injury can cause delayed cerebral ischemia without angiographic vasospasm. I don't believe completely this theory, but partly correct, I think. Another group make emphasis on microcirculatory disturbance and microembolism to cause delayed cerebral ischemia. So I would like to talk about the vasospasm treatment after subarachnoid hemorrhage. This is guideline for management of aneurysmal subarachnoid hemorrhage published by American Heart Association. According to this guideline, nimodipine or intraoral nimodipine is still most reliable drug to decrease, improve the neurological outcome after subarachnoid hemorrhage. Class 1, and this is only one class 1 and evidence a drug. And in the past, include me, triple H therapy was very good prophylactic therapy to suppress the vasospasm. But prophylactic hypervolemia cannot be recommended before development of angiographic vasospasm anymore. But still, induction of hypertension is recommended for patients with DCI. So it's worthy to perform the hypertension. And nowadays, prophylactic hypervolemia is not recommended, but normal volemia is very important. That means neurosurgeon try to keep the patient normal volemia and pay attention that patients suffer from dehydration. Dehydration is very bad for the patient because dehydration decreases the intravascular volume and disturbs the microcircular circulation. So normal volemia is very important. And transcranial Doppler is reasonable too to monitor the development of cerebral vasospasm. And also perfusion imaging using CT or MRI is very useful. So first, triple H therapy. 30 years ago, my job was to perform the triple H therapy for the patient after subarachnoid hemorrhage. Triple H therapy consists from hypervolemia and induced hemodilution and induced hypertension. Hypertension also induced by vasopressors. However, 10 years ago, meta-analysis shows that prophylactic triple H therapy was controversial. And this meta-analysis showed that published my data 30 years ago in stroke, and I was the only person who shows the prophylactic triple H therapy induced increased CBF. I use I made the machine to measure the local cerebral blood flow very correctly, but only to portion in the brain using the radioisotope. So triple H therapy is now controversy, and normovolemia is now recommended because the drawbacks of hypovolemia as follows: pulmonary edema. This is very bad situation. So when I was young, my job was to monitor the central venous pressure or pulmonary wedge pressure to avoid the pulmonary edema during the triple H therapy. It was a really tough job. I had to stay in NIH, ICU every night. So how about calcium antagonist? So nimodipine is only drug that meta-analysis shows effectiveness of the nimodipine. So, but nimodipine is not available in Japan. I don't know in India or other countries. But nicardipine is available in Japan, so we use the nicardipine. And as I said, intraoral nimodipine is has the effect to decrease the so-called decrease poor outcome. But nimodipine did not show the angiographic vasospasm. And do you know the nicardipine pellet? Nicardipine prolonged release implant is very potent and feasible strategy to prohibit the vasospasm. Professor Kasiya in Tokyo Women Hospital, medical hospital, invented this nicardipine pellet strategy. He's my best friend, one of my best friends, and this is angiogram immediately after subarachnoid hemorrhage, ACOM ruptured, and this is 7 days after the ictus operation. So he placed the nicardipine on the A1 and A2 and M1 and M2. So angiography shows that there's a no vasospasm, rather dilatation. We can recognize that. So nicardipine pellet is very potent strategy to suppress the major artery spasm. However, distal artery, we cannot place the nicardipine, and this needs operation, open surgery. We need open surgery. And I told about fascizyl hydrochloride. Fascizyl is a potent low kinase inhibitor, and I don't know. Japanese pharmaceutical company produced this drug, and in China, I found the fascizyl hydrochloride, but the Japanese company has never admit Chinese company to produce fascizyl. So, but problem is that there is no randomized international control studies about fascizyl. But honestly speaking, Fasidil is best drug for me to suppress the occurrence of symptomatic vasospasm because 20 years ago, since Fasidil was available, we have not encountered so much severe case of vasospasm in Japan. And actually, in Japan, young neurosurgeons do not have a lot of interest in vasospasm anymore. So I think Fasidil changed everything in Japan. I'm honestly, I'm honest. And clazosentan is an endothelin A receptor antagonist. And 10 years ago, we expected clazosentan solve everything. So Rock McDonald performs a randomized controls study, CONSCIOUS 1. And clazosentan clearly suppressed the occurrence of angiographic vasospasm, but no significant difference in mortality and morbidity. So we are so disappointed. And you can see clazosentan in dose-dependently suppress the vasospasm, but no effect in mortality and morbidity. And CONSCIOUS 2 study also could not show any beneficial effect on mortality and morbidity. So, but I heard that new clazosentan study has been going. I don't know detail about the result yet. So statins suppress the inflammatory inflammation and also improves the NO production. So statin may be one of candidate to suppress the delayed cerebral ischemia. However, meta-analysis showed any definite effect on delayed cerebral ischemia or poor outcome. So statin, from the point of experimental animal studies, it may have a beneficial effect, but it cannot reflect on the clinical studies. And vascular interventions. I'm not a endovascular surgeon, so I don't know much about angiography or intra-arterial delivery of vasodilatators, such as papaverine, verapamil, and Fasidil. But I think guideline recommends angiography or intra-arterial delivery of vasodilatators if the patient shows symptomatic vasospasm. But we have to repeat the endovascular interventions because angiography and intra-arterial vasodilatator delivery effective is short term. So almost every day or almost 12 hours, we have to repeat the endovascular treatment. So I think I think I cannot perform such repeating therapies. I'm very sorry for the endovascular surgeons. So how about magnesium? Magnesium ion has several beneficial effects, such as magnesium ion block voltage-dependent calcium channel, and magnesium inhibits the calcium-dependent binding site at calmodulin, and attenuate ETA and oxyhemoglobin effect. And magnesium block NMDA receptor, and magnesium block glutamate receptor, and magnesium suppress the cortical spreading depolarization, and magnesium suppress the platelet aggregation. So magnesium vasospasm, as I said, explained, vasospasm can be induced by many factors, and magnesium can suppress these many factors at once. So many neurosurgeons thought magnesium may be a good candidate to suppress the vasospasm. So, and as a fact, after the subarachnoid subarachnoid hemorrhage, patient plasma magnesium concentration decreased. So people thought that magnesium intravenous infusion therapy might prevent the vasospasm. However, the meta-analysis of intravenous magnesium infusion therapy did not show any beneficial effect on the result, on the clinical outcome. So next, I want to talk about the future prospect of treatment of delayed cerebral ischemia. And so something wrong, because so there is something wrong about delayed cerebral ischemia from the point of randomized control study. For example, Conscious One study definitely clazosentan reduced the vasospasm, but no beneficial effect in mortality and morbidity, neurological deficit. But nimogepin didn't prevent vasospasm, but improved the neurological outcome. These facts implies that delayed cerebral deficit may not be caused by only vasospasm. So we have to think about the possibilities of early brain injury and cortical spreading ischemia. So, but still, I believe we have to solve the problem of large vessel constriction, and also we have to solve the problem of early brain injury and cortical spreading ischemia. So let me return to the story of magnesium. So magnesium has many beneficial effects. So I could not give up about magnesium. But as I said, randomized control study of intravenous magnesium study showed no beneficial effect. But it is clear because magnesium ion cannot pass the blood-brain barrier. So even if we inject the magnesium solution into the intravascular intravenously, the magnesium concentration in perivascular space cannot increase at all. So it's nonsense to inject the magnesium intravenously. So I thought, how about the intracisternal direct infusion of magnesium solution? So I started this study more than 10 years ago. So my theory is that magnesium can suppress the classical vasospasm. I mean that can suppress the large vessel constriction. And also magnesium suppress the microcirculatory disturbance, microemboli, cortical spreading injury, and brain injury, early brain injury. So I started the experiment using the DOC SAH experiment, and I inject the magnesium solution directly into the subarachnoid space. And this is the angiogram, vaginal artery of the dog before SAH, and this is angiography 7 days after the SAH. And this is 1 hour after injection of the magnesium solution into the subarachnoid space, cisterna magna. Obviously, it ameliorates the severe vasospasm. This is an DSA before SAH and day 7, and immediately after the intracisternal injection of magnesium solution. And it improves the large artery vasoconstriction, but also improves the micro capillary circulation. Look at this. So I convinced that intracisternal magnesium infusion is very effective, and I used 100 beagle drug, and I determined the optimal concentration of magnesium solution. I published several experimental data, and also I published preliminary clinical studies. And I also think that molecular hydrogen is very feasible agent to suppress the delayed cerebral ischemia, especially magnesium can suppress the early brain injury. And molecular hydrogen is a potent free radical scavenger, and magnesium can pass through blood-brain barrier very easily. And as I said, hydrogen is a strong hydrogen radical hydroxyl radical scavenger. So I wanted to use hydrogen. So I thought to solve the to decrease the delayed cerebral ischemia, I have to suppress the early brain injury. I have to suppress the macrovessel vasospasm, and also we have to suppress the microcirculatory disturbance, and we have to suppress the cortical spreading depolarization. So once again, magnesium can suppress the angiographic vasospasm, and magnesium suppress the cortical spreading depolarization, and hydrogen suppress the early brain injury. So 7 years ago, we started randomized control study using the intravenous infusion of hydrogen-rich fluid combined with intracisternal infusion of magnesium solution in severe neurological subarachnoid hemorrhage, grade only 4 and 5. So I wanted to use hydrogen inhalation, but in Japan, hydrogen inhalation is not approved in ICU. Frankly speaking, less than 44% of hydrogen can never explode. So less than 4% hydrogen is very safe, but many doctors are afraid about hydrogen inhalation. So I had to use a hydrogen-rich intravenous infusion. So strategy is that 2.5 millimolar per liter magnesium solution was injected into the cisternal tube and drained from the spinal drainage tube, and hydrogen-rich fluid intravenously injected. And hydrogen-rich fluid we can use very easily using the hydrogen-rich water tank. We can immerse the commercially available electrolyte fluid vinyl bag into the water tank. So hydrogen easily penetrates into the vinyl bag. So we can make hydrogen fluid very easily. So this is a patient of grade 5 patient after subarachnoid hemorrhage, and the patient had the Sylvian hematoma. So I expected M1 would show severe vasospasm, but day 7, M1 did not show any vasospasm, and the patient did not show any delayed cerebral ischemia. So this is the result. So control group and only magnesium intravenous, intracisternal injection group, and this is intravenous hydrogen and magnesium intracisternal combined therapy. So 3 arms. So as a result, angiographic spasm, magnesium group, and combined groups significantly decreased the occurrence of angiographic vasospasm. And cerebral infarction, magnesium group and hydrogen and magnesium group also significantly decrease the occurrence of cerebral infarction. And poor outcome, only hydrogen and magnesium group significantly suppress the poor outcome. So I think my method, I think this is a little bit complicated, and I think we need a lot of energy to perform this combined therapy. But if the patient is very poor condition, I think it's worthy performing this little bit complicated therapies. So it's not popular in Japan, but I expect Indian neurosurgeon and other countries' neurosurgeon perform the study using the magnesium and hydrogen. And frankly speaking, only hydrogen inhalation may be effective to solve the delayed cerebral ischemia. So So it's worthy performing the hydrogen therapy. So please perform these therapies. So thank you for your attention. Thank you very much.
Thank you. Thank you very much, Professor Mori, for detailing the causes and management of cerebral vasospasm following subarachnoid hemorrhage. Now, may I please invite Professor David Hassan to say his comments.
Thank you so much, Roger. Professor Mori, this is a great presentation. It's very detailed, very comprehensive, up to date with the literature. So we thank you for doing your diligence and presenting this without any bias or anything. As you alluded to, vasospasm is very complex disease, is not one factorial, it's multifactorial. And a lot of people have done tons of work in the last 30, 40 years attempting to study each pathway and try to address each pathway. And I think we all fall short because we focus on one pathway instead of looking at the whole picture and addressing the whole picture, as you try to explain to us that you need some agent that addresses all these factors at once. And so I appreciate that. Two things I want to mention and ask you, and then I'll open the session for questions. The first one is you didn't mention about drainage. There's more CSF drainage specifically. There is ongoing early trials comparing EVD to lumbar drain, and people thinking that using lumbar drain is more effective in reducing the subarachnoid hemorrhage. So what are your comments on that? That's the first question. And then the second question, if you go back to the last slide, where you have the combined, the hydrogen and magnesium, and the x-axis, I noticed in the last slide, what is that number exactly? Is it death, death or number of patients or days? I didn't know what's the x-axis represent. Those are my two questions. Thank you.
Okay, thank you very much for a nice question. And the first question, spinal drainage. I love spinal drainage, and I believe spinal drainage is very effective to reduce the occurrence of vasospasm, because spinal drainage definitely reduce the amount of subarachnoid blood in the cerebrum. So clinical study also shows the spinal drainage is very effective. So I recommend neurosurgeon to perform the spinal drainage if the patient has a thick subarachnoid blood in the brain. So I think spinal drainage is much better than, I think, so-called cisternal drainage. And the second question is that the number of the patient in the group of the combined therapy, and I think only 15 about 15 patients. So, but it reached the significance. So I believe combined therapy is better than only magnesium therapy, because hydrogen probably strongly suppress the early brain injury. So this data also shows that delayed cerebral ischemia can be induced by only cerebral vasospasm.
Okay. Thank you.
Thank you. Thank you, Professor David Hassan, for chairing this session. May I please invite my co-host for today, Professor Liu, to say his comments.
Thank you, Professor Mori, for a nice presentation. I have seen that you put up the papaverine intra-arterial use. Do you routinely use for all high-grade subarachnoid hemorrhage, or you only use when there is a radiological or clinical vasospasm? My first question. Second, do you have any experience to use intracisternal papaverine? Because in my center, we routinely use it, and clinically, we can actually see a dilatation of artery intraoperatively. That's my question. Thank you, Prof.
Okay. First question, I think about the question about the intra-arterial injection of papaverine, right?
Yes, Prof.
Yeah. Intra-arterial injection of papaverine is very useful to dilate the cerebral arteries, just temporarily, only 1 hour or 2 hours. So as I mentioned, intra-arterial injection strategy, we have to repeat. It's a drawback. So as you mentioned, intracisternal injection of papaverine may be better than intra-arterial injection of papaverine. But you know, papaverine is potent dilatator of spastic arteries, but may have drawbacks, especially to the brain tissue, because papaverine may be harmful. We do not know the effect of the papaverine on the brain, especially papaverine pH is low, acidic, and the high concentration of the papaverine should be very harmful to the brain tissue. So it's my answer.
Yeah, many times it has been reported to cause unilateral dilatation of the pupil because of the third nerve irritation, as well as it is also postulated to cause seizures because of its low pH. So that is one disadvantage. Yes, Professor Parthare from Liverpool, would you like to comment?
Thank you, Professor Mori. A wonderful talk. I learned quite a lot from it. A few questions. One, I wasn't very sure about the Rho kinase drug that you were using and what was the effect from it. Was it effective or not?
Effective, very effective.
Not effective.
Yeah, effective.
It was very effective.
Yeah.
Okay. So what are the Japanese guidelines for treatment of subarachnoid hemorrhage? Are you following the American Heart Association guidelines in clinical practice, or are you incorporating hydrogen and magnesium in the pathway you mentioned, in addition to nicardipine and the pellet formulation? What's the official guideline in Japan?
Japanese guideline recommends the use of Pathological and never recommends hydrogen and magnesium.
Okay.
Believe me, Pathological is a very strong inhibitor of Rho kinase.
Right.
So almost 40 years has passed since I became a neurosurgeon, but 20 years ago, situation has changed. Immediately after the introduction of Pathological in Japanese Neurological Society, and it is currently it is very rare to see the patient of severe vasospasm in Japan. So frankly speaking, young Japanese neurosurgeon has lost their interest in vasospasm.
But they're not seeing much of it. Very good.
Right.
Patients are gaining from it. The other question I have.
Outcome is became very good. So one slide I showed in years ago, symptomatic vasospasm occurs 30%, but nowadays about 5% in Japan. I believe this is due to the paucity.
Yes. The other question I have is about the spreading cortical depression hypothesis that you have, which we use in epilepsy. What drugs are you using, and is that in clinical application? And how do you think that works to prevent spasm?
Okay.
Concept of spreading cortical depolarization leading to vasospasm.
Right.
What is etiology, and what are the therapeutic interventions, including in clinical practice? Thank you.
Delayed cerebral cortical spreading depression. In the situation of subarachnoid hemorrhage, it causes microcirculatory disturbance. So, cortical spreading depolarization causes cortical spreading ischemia, and this is the main cause of delayed cerebral ischemia. But we do not have any evidence that that kind of drug can suppress the delayed cerebral cortical spreading depolarization. And in my laboratory, my colleague is studying about the effect of magnesium to suppress the cortical spreading depolarization. So we will be able to publish a new strategy to suppress the cortical spreading depolarization in near future.
On that concept of cortical depolarization, it's basically the neuronal potential changes, which are sodium channel driven. So have you tried any sodium channel drugs? And how do you explain the depolarization shifts in the neurons affecting the muscle contractility of the blood vessels to cause contraction, the microthrombi and the microcirculation things? How is the neuronal depolarization causing vascular changes as part of your hypothesis of cortical spreading depolarization?
It's a very difficult question.
It's a fundamental question, a fundamental neuronal shift to vascular shift. And a sodium channel effect there, which you have tried or not, because you're going on the magnesium pathway and calcium pathway mainly in your talk. But what about the sodium channels on that hypothesis? Do they work, or is there?
I think it may be sodium channel, maybe a key channel for the DC delayed cortical spreading depolarization. So I think, but I don't think we are good. We do not have a good sodium channel blocker. But I think anti-epilepsy drug maybe may have a effect to suppress the sodium channel.
Yes.
So I think some of the anti-convulsive drug may be useful.
Is it possible to say something?
Yeah, please, Professor Hassan.
So Partha, I mean, first of all, this is still a hypothesis in the making. It's still a hypothesis generating. And yet there's a lot of information to come from that. There's a few pockets, if you will, that populating or popularizing this idea. And if it really makes a difference, as you will, all these patients of subarachnoid hemorrhage are on anti-seizure medications.
That's right.
Whether it's phenytoin, whether it's Keppra, whether it's anything. And pragmatically, we have not seen that. This has been ongoing for almost 20, 30 years. So if I am an outsider and just looking and say, well, okay, if you suggest anti-seizure medications could modulate or attenuate the cortical spreading, you would see already an effect, correct? So again, it's a complex process. Maybe in 5 years or 10 years, will sit back and reflect and say, you know, like you said, but I think it's still in their infancy.
And
it's,
all these pathways that Professor pointed out are sequential. So which drug at which point and which ion at which stage of the spasm will also play a role. So it's not all at
no,
once.
that's what we failed in the last 30 years, is we focused on one pathway.
That's
We did not focus on the whole picture. And that's what Professor Mori trying to address, is the whole complex. It's not one pathway. Everybody was very excited about endothelin A1. I mean, it was the hype, and before that, many things, but everybody focused on one pathway. And that's, we don't want to go into back to that circle. I think we want to address the whole picture. And if there's a medication that can address the whole picture, as magnesium, if you will, or anything similar to it, I think it's will be the ultimate, because we're really not changing. The ultimate thing is to change the morbidity and mortality, and that's where we need to.
Right. Thank you. Thank you very much. There are so many lacunas yet to be filled. Thank you, everyone, for chipping in. Yes, Professor Mathuria would like to comment. Professor Hassan Mathuria.
Yes, since there are so many reasons of the vasospasm, that's the reason we are unable to find what is the exact therapy for this. So, but there is no doubt that the hemoglobin is responsible for it. That's the reason the thing which had been going on long time back about the lumbar puncture drainage of the CSF, that had come back recently, and not recently, quite a few years back. And we ourselves in PGI have found that it was really effective. So that's what we used to do. We used to drain around 40 ml of CSF every day in grade 3 subarachnoid hemorrhage, maybe for about 4 to 5, about 7 days, and trying to do the, say, the TCD and see when the vasospasm is settling down. The second thing is about the fasudil. Say, fasudil in 2020 in Cerebral Vasospasm conference in Interlaken, Dr. Shibuya from Nagoya University, he has presented about that. And he presented quite good figures. And as you are also telling that it's quite effective. But unfortunately, in India, we are not getting this. Otherwise, we also will have the same effect in our subarachnoid hemorrhage patients. Then about the nimodipine. Nimodipine oral is as effective as the intravenous nimodipine. Intravenous nimodipine doesn't have much of the edge over the oral nimodipine. In between, there was a trial about the nimodipine paste to be put up at the time of clipping of the aneurysm, but nothing much has come out of that subsequently. Then the nitric oxide. Nitric oxide, actually, we performed a study about the nitric oxide delivers. Like we used to put sodium nitroprusside intraventricular, and we had a thesis study with our resident. But since it was to be put intraventricular, it used to cause some problem. So there was a cyanide toxicity and all. That's the reason we abandoned that. But immediately after putting it in the ventricle in high dose, we saw that the vasospasm disappeared. So that is something. And about the nitric oxide, lot of work has been done by Dr. Suzuki from Nagoya. Then about the endothelin A2 receptor antagonist, that is clazosentan. Say PGI was the largest center involved in this study, CONSCIOUS 2 study there. But what we found was that the elderly patients, the patients with history of smoking, the patients with the history of bad chest really had lots of problems. So that's the reason this drug has not been found to be effective. If you go into the mechanism of vasospasm because of the endothelin, then you find that it's going to be very effective. But these are the reasons that it was quite toxic. So that's the reason it was not found very effective subsequently. There is one thing which has not been touched, is milrinone. If you give say the intravenous milrinone with monitoring of your blood pressure and the pulse, then it's very effective. In many patients, we found this. What we used to do is that we do the TCD maybe 2-3 times a day. We used to have a TCD machine in the intensive care itself. And we find that the TCD shows vasospasm. Clinically, the patient has got vasospasm. We'll give triple H, and we see that the patient is not recovering. don't give more than 2 hours. After that, we used to shift the patient to the radiology. They used to give intraarterial nimodipine, and they used to give intraarterial methadone also. So these are the things which we used to do, and still it is a subject to which there is no 100% answer.
Right. Thank you very much, Professor, for giving your comments. Yes, Professor Hideto Kimura is here. Kimura Sensei, would you like to come in?
Hi, Professor Kentaro Mori. Long time no see. How are you?
I'm fine.
Yeah, it's so fine. I'm so happy to see here.
Okay.
So I'm so thank you for a nice, excellent presentation and explaining in detail the mechanism of the vasospasm. I learned so much. So actually, I less chance to never encounter the severe vasospasm post-operative subarachnoid patient, hemorrhage patient. So mainly, this is my comment. In Japan, the number is decreasing. Why? In Japan, we use the silostazole. Mainly, yes, as you know, this is Japanese pharmacy. Only limited in Japan we can use this silostazole. So how can do you have some opinion?
I understand. I agree with you about the occurrence of severe vasospasm. We never encountered so much in Japan. First of all, the treatment of ruptured aneurysm has been improved, I think, without much injuries during the operation, or endovascular treatment also introduced a lot, and then it did not cause a brain injury during the treatment. And another factor is we already established good post-operative therapies. Patients never suffer from the dehydration. We pay attention to keep the fluid balance after subarachnoid hemorrhage. But you mentioned about silostazole. I agree, silostazole is an antiplatelet drug, and also it causes a microcirculatory disturbance, improvement of microcirculation. But I have never used silostazole, but I do use a Fasudil. So I still believe the Fasudil is much more important than the silostazole. And I think you use not only silostazole but also Fasudil, right?
Yeah, I agree with you, but yeah, partially agree with your comment. So I very strongly responsible in the use of silostazole post-operative patient to the subarachnoid patient, because I never encounter severe patient with causing to the severe morbidity and mortality, of course, recently.
But
no.
these patients did not receive any Fasudil, or do you use a Fasudil?
Yeah.
So without Fasudil,
sorry, yes. Actually, I use the Fasudil also, but not only Fasudil, I also use silostazole. Is much more effective to post-operative patient.
So you have to perform the randomized prospective.
Yeah,
study.
we need to. Yes, it's my ongoing study. Yes,
So
this is my comment. Yeah,
for sure.
I'm sorry. Yes, I just want to ask you a comment. Yes, about this regarding to this problem.
Pragmatically, in the United States, we use 0 Fasudil. We use 0 Fasudil.
Okay.
0. And our morbidity is as good as in the Japan.
I see.
So the subarachnoid hemorrhage morbidity and mortality, and I don't know about England or other countries, but the morbidity and mortality has decreased a lot. So to contribute all the success in Japan to Fasudil, possibly, maybe, but what about in America? We don't use, no one, I will tell you, no one, zero
Okay.
is Fasudil. Now back to silostazole. Antiplatelet, because again, microthrombosis, Dr. Suzuki, Professor Suzuki showed that microthrombosis does play a critical role. And there was a trial with aspirin or different things. And we published data on that. And there was a recent meta-analysis. And we just finished a phase 1/2A using continuous IV agrostat for 7 days, and mainly for safety, but we show close to efficacy. So again, you cannot contribute a whole picture to one medication. Please, and that's what the whole thing is, we cannot. I mean, what's successful in Japan, we probably, again, example, the Fosadel, that Professor Mori says the success in Japan is due to only Fosadel. Again, that's not the case in the United States. So how do you explain that?
I think that there should be a genetic variation and susceptibility to vasospasm as well in various countries. I think that should be explored.
You're politically correct, Professor Raj.
My dear friend Satish, are you here? Satish?
Yes, Dr. Raj, I'm here. It was very nice lecture, Professor Mori. I would like to know what is your duration of using Fosfidil? For how long do you use it?
14 days, 2 weeks.
And what is the dosage? Is it oral or?
Intravenously.
Intravenously, right.
14 days consecutively.
Can I ask one more question, Professor Mori?
Yeah.
Yes, I see in Japan, in Subarachnoid Hemorrhage, surgeons spend quite some time to do a systemic washout. So my question is, for example, a case of a ruptured ACOM, which are suitable for both microvascular clipping and also endovascular. So would now the extensive systemic washout give advantage to the patient to be on the side of a microsurgery than endovascular procedure, Professor?
Okay, about ACOM, ruptured ACOM aneurysm in Japan nowadays mostly treated by endovascular treatment. But I'm a clipping surgeon, so still I like to clip the ruptured ACOM aneurysm. But problem from the point of washout of subarachnoid hemorrhage, some investigator reported that endovascular treatment, after the endovascular treatment, subarachnoid blood spontaneously disappeared more rapidly than clipping surgery. So endovascular surgeon recommends endovascular coiling from the point of preventing the vasospasm. But still, I love clipping.
So then I would like to comment on one of your point that you said, that you pointed out of one of the studies of Professor Hidetoshi Kasuya about the nicardipine pellets. So when I met you last year at Phuket, last year for the ISMINS meeting, and we had an extensive talk about vasospasm and all. I got this idea from you about manufacturing these pellets in India. I came back to India and I discussed with various institutions about manufacturing these pellets. And I studied extensively, and I read about many studies, experimental studies, which used different technologies. I read that Professor Peter Vascosi from the Charité, they mixed in nicardipine along with this fibrin glue. And they sprayed this fibrin glue mixed with nicardipine in the cisternal at the end of the surgery, and they found the incidence of vasospasm was very low. And after that, there were polymers of nicardipine which are pasted on the cerebral arteries, and they also found that the incidence of this was vasospasm was very low. And then Professor Kasuya then. I mailed to Professor Kasuya, and Professor Kasuya is in collaboration with one of the pharmaceutical companies in Japan, and is actually manufacturing this on a commercial basis, and it will be available in the Japanese market very soon. That is what the information I got, and probably it will be available to the world market also in the future also. As you said, and I read all his papers, and it was found to have a very good results for cerebral vasospasm. And
right.
Yeah,
I want to warn you. You know, have you read the results of Newton trial 2?
No, I didn't read that.
Yeah, that's failed.
Yeah, isn't?
Yeah, so they you know, the guys from Germany, with Lock McDonald, they did that intraventricular and through microsurgery using the nanoparticles of nimodipine, and it did not.
Fine.
Yeah, the results should be out in the literature. I had to review the results. So be cautious before read the manuscript before you proceed.
Yeah, we'll see it when the results are out, sure.
Yeah.
So then I think we'll wind up this session. On behalf of the Education Committee and the President, Professor Yoko Kato, I would like to thank Professor Mori for giving us such an excited lecture about vasospasm, and Professor David Hassan for chairing this session, Professor Liu for being my co-host, and wonderful audiences who came here and gave us a wonderful discussion. So until next Wednesday, it is bye-bye from all of us.